So I will try to very briefly talk a little bit about some of the things that we've been working on at Queen's related to some of the health systems challenges that are going on these days, where we think some of the wins are, and what we're doing to try to demonstrate how we could implement those wins. And if we have a little time left, if you have questions, I would be very happy to either hear questions or your good advice. So this has been a really interesting week. I'm sure if you're interested in healthcare, and I suspect all of you are, it's been an interesting week for us all as we sort of were awaiting the big federal, provincial, territorial health discussions that were taking place this week between the premiers and the prime minister. And so it's meant that there's been a lot of Canadian discussion. Of course, that's in the context of the fact that the challenges in health systems, I don't think have ever been as urgent as they are right now for at least a generation. I've been a family doctor now for almost 40 years, and I don't think I've ever seen things quite as bad as they are right now in Canada. So that's because those cracks have been widening for a long time. And of course, the pandemic made it worse. And then, of course, this team that you're meeting together today, you're well aware of the new data that came out through the Our Care project, talking about quantifying the gaps, and particularly the gaps in primary care. So thank you to those in the room who were involved in demonstrating through some of the survey work that was done that there are now about 6.5 million Canadians that don't have access to primary care. So I'm going to start there. I'm not going to I will try not to repeat things that you already know and have heard 100 times already in your time together. But I think it bears repeating just how important primary care is to the fix that we're all looking for. So having been a family doctor in Canada for quite a while, but also having worked as a family doctor in the poorest country in the world, in Niger, West Africa, I am fundamentally convinced that countries that have good systems of primary care will get the best health outcomes at the most affordable cost in a way that's accessible and equitable. And in Canada, we're doing I'm trying to use nice words. We're not doing a great job of access to primary care. We now have about 20% of the population that doesn't have a home, and you deserve a primary care home, just like every child in Canada deserves and actually has access to a public school. What kind of country thinks that it's okay for 20% of their people not to be able to have a place to go when they need care? And they're left, as you know, having to go to emergency departments or not get care at all, or just delay their care for so long that it will be more problematic and sometimes not even treatable if they wait too long. So what can we do on that? I am firmly convinced that we can change our systems in Canada. We can change to a system where every Canadian will have access to a primary care home. And we all need to say it loudly and firmly and over again until we see the leadership changes that are necessary. So we are trying to model this out in Kingston. I won't go into long details around how primary care models have been, and there has been innovation in Ontario over the last 20 years or so, but we still haven't fundamentally got it right. We need primary care models that are based on the health of the entire population, not just where a doctor or a nurse practitioner can sign up a group of people and they care for that group in theory, and it doesn't matter to them what happens to everybody else. We need a model where actually everybody has access to care. So we've developed a model in Kingston that we are eagerly awaiting final approval from the province that they will fund it, where we have a primary care team that will be open 12 hours a day, 7 days a week, and it will be staffed by family doctors, nurse practitioners, registered practical nurses, a social worker, a dietitian, a PT, and an OT, etc. And where you will come, that will be your home. And on the particular day that you come, you might see a family doctor because that's who you might need to see. But if you don't need to see a family doctor, maybe you'll see a nurse, or maybe you'll see the dietitian or the social worker. You'll be triaged according to your care needs. I know there are other people, including some in the room, who are working on similar kinds of models. I'm pushing the province to say, please fund our project, and then we want to actually roll it out so that we can actually be one of the first regions in the province to say that every person who lives in our region has a primary care home. It's totally doable. It's affordable. We've worked it out that it would cost about $500 per person per year, which sounds like a lot of money, but it's totally affordable in the long run. And that if you do that and that one person avoids an emergency department visit, you've probably already saved money on that. And if you get them out of the hospital one day earlier, you've already saved a year's care costs for that person. So that's one thing. The second project is around health workforce. And I think that's one of our other big challenges after primary care is the real devastation of the workforce. The numbers of health workers has gone down significantly. Those who are still plugging away on the front lines of care are not always in a good space. They are morally distressed. They are burned out. And we really have to do something to rebuild the health workforce, and particularly to get people working in areas where we need the help the most. So let me give you an example of something that we're working on at Queen's in this regard. And I apologize that it's another medicine example. We actually do have both nursing and rehab at our faculty as well, but this happens to be a model to look at why the fact that our medical students are every year less and less often choosing family medicine. This is the lowest numbers we've ever seen for the number of people that graduate from medical school and go into family medicine. So we're doing something wrong at medical school right now that is discouraging our young people from choosing a career in family medicine. So one of the things that we've done is that we got 20 new seats for our medical school this year. And we specifically are opening a new campus in the Durham region. Any Durham region folks out there, Lake Ridge Health folks? So we are partnering with the wonderful people at Lake Ridge Health and dedicating these 20 new seats to students who make a commitment when they start that they will become family doctors. And we will have a modified curriculum that will make sure that their placements, their teaching are family medicine and generalism focused. And they will be able to actually go seamlessly from medical school right through to their family medicine residency with the support of their communities where they will be placed from the very first year of their time in medical school to start to build attachments in communities. So we're really excited about that. Never been done before in Canada, and there's a lot of interest in whether or not this could be a new model. It's based on some work that's been done in other countries. And then the last thing that I will just share with you that I wanted to just make sure is on your radar, I suspect you've already been talking about it, but the disparate access to care is definitely affected by things like geography, race, and ethnicity, for example. Having been Minister of Indigenous Services, I can tell you that the health outcome gaps experienced by First Nations, Inuit, and Métis in our country are really quite I don't know whether to use the word shameful, but they are not something that we should be proud about as Canadians. The fact that First Nations and Inuit in particular, that their life expectancy is a decade or more shorter than non-Indigenous Canadians. Tuberculosis rates amongst Inuit 300 times higher, higher than the rates of Canadian-born non-Inuit. I could go on and on with statistics, but the bottom line is we haven't done well, and there are a bunch of reasons why. A lot of it has to do with just denying the rights of Indigenous peoples, etc. But I did want to share sort of encouraging projects and news as well. So, and I know that Tara and others in the room are working on other projects addressing the disparities in outcome gaps for racialized individuals. But here's a project that we're doing at Queen's, which I'm very excited about. We decided that one of the reasons why there are not as many Indigenous youth going into our programs, whether it be nursing or medicine or other programs, was just the geographic gaps, not to mention the cultural gaps. So at Queen's, we've had a partnership with Moose Factory, for about 50 years or more, where we've been sending doctors and nurses up to Moose Factory and where they've been sending patients down to us in Kingston. And we decided a few years ago that rather than expect, even though we've got a great clinical partnership, it should also be an educational partnership. And so I'm really happy to say that we got a really nice gift from the MasterCard Foundation to help develop a campus in Moose Factory. Actually, it's going to be in Moosonee, where there's a new hospital being built. And we're going to start, we've already started working with high school students to help make sure that they've got the prerequisites they need to become nurses or doctors or OTs or PTs or midwives or paramedics. But we will be starting in the next couple of years to be actually delivering post-secondary courses for nursing and the Bachelor of Health Sciences, and eventually we hope a small medical school campus in the James Bay Coast region to add on to the training that's already happening in the northwestern parts of the province. So hopefully that gives you an idea of some of the things that we're focusing on. And I think there's reasons for hope, because I know that all of you in the room are also working on projects, and we just need to get at it together and make sure that our leaders know that we need to do better, because health is on the minds of the people of Ontario, the people of Canada. So I'll leave it at that. And if you have time, if you want to ask me a few questions, I don't know what your schedule permits.